Hi, everybody. I'm Kavitha Chinnaiyan, and I'm a cardiologist at Beaumont Hospital in Royal Oak, Michigan. Today, I will talk about when to order coronary CTA in the emergency department and how to use those results. The first point to consider here is that of acute chest pain, which is very different than evaluation of stable coronary artery disease or stable chest pain. Here, we're talking about cost-effective triage, which is essentially efficient early testing with high diagnostic accuracy combined with a low miss rate of acute coronary syndrome, which by consensus is less than 1%. What is it that we want to know in the emergency department? First of all, are these symptoms of cardiac ischemia? Secondly, does the patient need immediate revascularization? And third, are there concerns for other potentially life-threatening conditions that could be causing these symptoms, such as pulmonary embolism or aortic dissection? As far as coronary CT angiography is concerned, there is very strong evidence for its use in the emergency department for many reasons. It can be performed rapidly. It is highly accurate with very high sensitivity and very high negative predictive value. When you combine high sensitivity and high negative predictive value, it's a very good test to rule out a particular condition. In this case, coronary artery disease. Coronary CT angiography has very excellent plaque characterization capabilities and has been shown to have a very high prognostic value because it can identify not only obstructive coronary disease and the degree of stenosis of coronary arteries, but also identify non-obstructive disease as well as the overall atherosclerotic burden in a patient, all of which play a very important role in assessing prognosis over the long term. Additionally, triple rule-out scans can be performed, which have the potential to assess fatal non-cardiac issues of chest pain, such as pulmonary embolism or aortic dissection in the emergency department. Coronary CT angiography is most useful when the arteries are normal, again, because of its very high sensitivity and high negative predictive value. When it comes to utilizing CTA in the emergency department, there is a very quick and easy decision pathway. The first thing to consider is this: is rapid, high-quality CTA available at your center? Next, is this patient a good candidate for CTA? What does that mean? The first thing to consider is, has STEMI or ST elevation myocardial infarction been ruled out in this patient with biomarkers and EKG criteria? Obviously, because STEMI patients are not appropriate patients for CTA and must go to guideline-directed therapy and investigation, including to the cardiac catheterization laboratory whenever appropriate. Number 2, are there any contraindications to coronary CT angiography in this patient, such as poor renal function, heart rhythm disturbance, or pregnancy? The last thing to consider is this: is CTA an appropriate indication in this patient? Which essentially means, are they low to intermediate risk for coronary artery disease? Do they have a somewhat lower likelihood of significant coronary artery disease? Because again, remember, the strength of coronary CTA is in ruling out disease. Also, patients should have no known coronary artery disease, such as bypass grafts or coronary stents. They are very good candidates if you're suspecting a coronary anomaly. And CTA is also a very good test if a previous functional study was inconclusive or discordant with the patient's symptoms. Now, how do we use these results? Let's use this visual. You have performed a coronary CTA as either the first test or after a previous functional test. Now, there are three possibilities. One is that there is no coronary artery disease, or there is mild or non-obstructive disease, which is defined as less than 50% stenosis. In this case, the patient could go home with preventive therapies for coronary artery disease, even if they have non-obstructive disease. However, if they continue to have symptoms in the presence of non-obstructive disease, we could and should consider workup for INOCA, or ischemia in the presence of non-obstructive coronary artery disease. On the other end of the spectrum is that the patient has severe disease. And severity is defined by the institution or the center. At our center, we call it severe if there is more than 70% stenosis in a coronary artery. In this case, the patient could go for invasive assessment to the cath lab, and they would obviously be very good candidates for preventive therapies for coronary artery disease. The third possibility is that the patient has intermediate or inconclusive disease, which is defined as anything between 40 and 90% stenosis, most commonly 50 to 70% stenosis. In this case, we can consider additional testing with either FFRCT or CT-derived fractional flow reserve, or CTP, which means CT perfusion. Both modalities can be used if they are available at your center. Or, if neither is available, consider stress testing if CT was indeed the first test. Additionally, these patients would also be candidates for preventive therapies for coronary artery disease. Now, that's a very easy way of understanding when to order CT in the emergency department and how to use these results. Hope this was useful for you. Thank you very much.
Hi, I'm Eric Williamson, past president of the Society for Cardiovascular CT. Thanks very much for taking the time to view this video from SCCT's Referring Physician series regarding the appropriate application of cardiac CT. I hope you found it helpful for your specific practice as well as for your patients. Please join us for other lectures from this 6-part series. I'm confident they will be equally as enlightening. See you then.